Okay, let's take a deep dive. We're cracking open a really specific, crucial clinical topic today, straight from some high-yield revision notes you've shared with us,
Yeah.
navigating chickenpox exposure in pregnancy.
That's right. Yeah, whether you're knee-deep in exam revision, say for the MSRA, or you just need to get up to speed on this fast, our mission is really to unpack this source material, zero in on the absolute must-know information, and make it stick for you.
Exactly. Think of this as your focused, essential guide. It's a scenario that carries, well, pretty significant implications.
It really does.
We're going to go section by section, just like the notes, pulling out the key threads, covering everything from the definition, the risks involved, right through to diagnosis and those all-important management decisions.
And we'll aim for clarity, obviously, pull out those high-yield facts.
Yeah, and hopefully connect the dots in a way that makes sense and, stays with you.
It's about understanding not just the facts, but the critical interplay, especially as you'll see regarding timing.
Timing really is everything here, isn't it? So let's jump straight in. What does chickenpox exposure in pregnancy actually mean, according to these notes?
Well, at its simplest, it just means a pregnant woman has come into contact with the virus that causes chickenpox. That's the Varicella-Zoster Virus, VZV.
Right, VZV.
And this contact could be through being near someone with active chickenpox or shingles or even, certain environmental exposures.
And the notes, well, they waste no time hitting you with the big picture risks. These are the things that immediately demand your attention.
That's not.
For the mother herself, if she does get infected after exposure, there's a significantly increased risk of developing pneumonitis, a lung infection. The notes specify it's around 5 times higher risk.
5 times, yeah.
Yeah,
Compared to the general population, that's a really critical maternal risk to remember.
absolutely. But then there's the impact on the baby.
And what's particularly striking there is how the risk profile shifts so dramatically depending on when in the pregnancy the mother actually gets the infection.
This is where you really need to pay attention for revision, I think. The notes highlight fetal varicella syndrome, or FVS.
FES, yeah. It's a major concern if the mother gets infected relatively early on.
Early on, meaning?
The notes put the risk at about 1% if the maternal infection occurs before 20 weeks gestation.
Okay, before 20 weeks.
It becomes rare between 20 and 28 weeks, and here's a really high-yield fact. The notes state it's essentially not seen after 28 weeks. So FES is primarily an early pregnancy thing.
That distinction is vital then. Before 20 weeks, worry about FVS. After 28 weeks, much less concern for FVS itself.
Exactly.
And FVS isn't just like a minor thing. The notes list some pretty serious potential outcomes.
Oh, yeah. Skin scarring, eye defects, limb abnormalities, microcephaly, a smaller head, and learning disabilities, too. It's a complex, severe syndrome.
Wow.
It certainly is. But the notes also point out other risks to the baby, even outside of that early FES window.
Right. Shingles in infancy is mentioned. That can happen in, 1–2% of babies if the mother was infected during the 2nd or 3rd trimester.
Yeah, it's like a delayed presentation of the virus catching up with them later.
And then there's the other major and perhaps the most alarming risk highlighted, severe neonatal varicella.
Right. This is different from FES. It relates specifically to infection acquired right around the time of birth.
The timing here sounds incredibly tight and critical. The notes say the severe risk occurs if the mother develops her chickenpox rash anywhere from 5 days before delivery up to 2 days after delivery. That specific perinatal window.
Yes, exactly. That short time frame around birth is when the baby is most vulnerable to developing really severe disseminated chickenpox. Like the infection spreads everywhere.
And the fatality rate given in the notes for that, it's high.
Tragically high, 20%. That number, you really need that to stand out when you're revising, 20%.
Wow. Okay. So just to sort of condense those initial high-stakes facts from the notes, the 2 biggest fetal or neonatal concerns linked to the timing of maternal infection are FVS, if it's before 20 weeks, and severe neonatal varicella, if the rash appears in that critical window around birth 5 days before to 2 days after.
Precisely. Lock in those 2 timings and their associated severe risks. Those are key.
Okay, that definitely lays out the why we care. Now let's quickly touch on the etiology of what actually causes this.
Simple fact here. It's the Varicella-Zoster Virus, VZV.
The same one that causes shingles later on.
Exactly. It stays dormant and can reactivate.
And how does this VZV spread? How does someone actually get exposed?
Well, it's highly contagious. The notes are clear. It spreads mainly through respiratory droplets, so breathing it in from someone infected,
Right.
or through direct contact with the fluid from the chickenpox blisters, or, importantly, shingles lesions, too.
Okay. So who is particularly vulnerable then when exposed?
The key factor, and this comes up again and again in the notes, is the lack of immunity. Pregnant women who haven't had chickenpox before or haven't been vaccinated, they're the ones at significant risk of getting infected if they're exposed.
Immunity status, that's central.
Absolutely central to the whole management pathway.
Which naturally flows into the risk factors section. Based on what we just discussed, the risk factors seem pretty straightforward.
Exactly. The notes list close contact with someone who has active chickenpox or shingles,
Makes sense.
and the overarching factor, lack of immunity to VZV, it all comes back to that.
They also briefly mention environments with higher VZV transmission risk, like maybe healthcare settings or schools, places where close contact is just more common.
Yeah, those are the straightforward elements that increase the chance of exposure. And then if you're not immune, the chance of infection.
So once this virus gets into a pregnant woman's system, how does it potentially get to the baby? Let's look at the pathophysiology described.
The mechanism is explained quite simply in the notes. VZV typically gets in via the respiratory tract.
Breathing it in.
Yeah, and then it spreads systemically through the bloodstream.
And the crucial step then, the link between the mother's infection and the baby's issues.
The notes explicitly state that VZV can cross the placenta.
Ah.
That placental transmission, that's the pathway. That allows the virus to reach the developing fetus and potentially cause the problems we've talked about, whether it's congenital varicella syndrome, CVS, or other issues.
So it breaches the placental barrier.
That's the key step leading to the fetal complications.
Okay, virus gets in, spreads through the mother, potentially crosses the placenta to the baby. Simple but critical concept. Now, the notes briefly cover differential diagnosis. If you see a rash in a pregnant woman that could be chickenpox, what else should be on your mind, according to this source?
The notes specifically list measles and rubella.
Right, okay. That's a high yield point for clinical practice and exams, isn't it? You see a pregnant woman with a rash, you have to think about these other serious viral infections too, because they also carry risks in pregnancy.
Absolutely. It's not just chickenpox you're thinking about.
Yeah.
Requires careful differential diagnosis.
Let's touch on the epidemiology, specifically the figures provided for the UK context. How often does this actually happen?
The notes give us a figure. Approximately 3 in 1,000 pregnant women in the UK are exposed to chickenpox each year.
3 in 1,000. So exposure isn't incredibly rare, even if severe outcomes are less common.
Exactly. Exposure happens.
And the epidemiology section reinforces a point we've already hammered home, but it's worth hearing again. Higher risk of severe complications when infection occurs within the first 20 weeks of pregnancy.
It just underscores that critical timing for FVS that we highlighted right at the start. The data backs up the clinical concern about early pregnancy infection.
So what does chickenpox in pregnancy actually look like? Clinically, is there anything different about the presentation compared to, say, a child or another adult?
According to the notes, the clinical presentation is essentially the same. No major differences described there.
Okay, so the classic features. What should we be looking for?
The defining feature is the itchy rash. The notes describe it having vesicles, those little fluid-filled blisters, and appearing at different stages of development across the body.
Yeah.
You might see spots, bumps, blisters, and crusts or scabs all at the same time. That's quite characteristic.
That crops of lesions appearance, and along with that rash.
General viral symptoms, usually.
Yeah.
Fever, malaise, just feeling generally unwell, tired.
Yeah.
And sometimes respiratory symptoms can occur too.
So that polymorphic rash, plus fever, plus an exposure history, that's your main clinical clue.
Exactly. That picture should make you think chickenpox.
So if you suspect it based on how it looks in the story, how do you confirm the diagnosis and, crucially, assess the risk? Let's look at investigations.
The notes are pretty clear the diagnosis is primarily clinical.
So based on what you see and hear?
Yes, based on the rash appearance, the symptoms, and getting a good exposure history from the patient. Did they recently encounter someone with chickenpox or shingles?
So looking and asking are the first-line tools. What about lab tests? Blood tests?
Serological tests, blood tests looking for antibodies can be used. The notes say these can confirm the diagnosis if there's any doubt.
Okay. But crucially, their main role in this specific scenario, pregnancy exposure, is often to check the woman's immunity status.
Ah, right. Does she have antibodies already?
Yeah.
From a past infection or maybe vaccination?
Exactly. Because, as we said, that immunity status is just so vital, it dictates everything that comes next.
Right. So the flowchart kind of starts with clinical assessment, history.
Yeah.
Then, if needed, or Really always to assess the risk properly. You do a blood test to check immunity and maybe confirm the diagnosis at the same time.
Precisely. Knowing that immunity status is what directs the management pathway.
And that brings us nicely to probably the most complex, but arguably the most high-yield section in these notes for clinical practice and exams, management, specifically in the UK context provided.
Wow.
What's the main goal when a pregnant woman is exposed?
Well, the notes state the overall goal is pretty clear. Prevent or minimize the effects of the infection on both the mother and, crucially, the fetus.
And the absolute first step, which you just flagged, you must check the mother's varicella immunity status with a blood test, if it's not already known for sure. Her immune status is the pivot point for all subsequent decisions.
Because if she's immune...
If she's immune, the risk is minimal, and generally no specific intervention like VZIG is needed after exposure, so you need to know.
Okay, so let's focus on the core scenario. A non-immune pregnant woman after a significant exposure. What do the notes advise then?
This is where gestational age becomes absolutely critical for prophylaxis, for trying to prevent infection. If she is 20 weeks, gestation, and non-immune after exposure.
So early pregnancy, non-immune, exposed.
The notes recommend administering Varicella-Zoster immunoglobulin, VZIG, and importantly, administering it promptly, as soon as possible.
VZIG given quickly for early pregnancy non-immune exposure. Got it. Now, here's a detail that really stands out in the notes, and it feels like something that could easily trip you up if you're revising. What if the non-immune woman is exposed, but she's greater than 20 weeks gestation?
Right. This is a key distinction.
The approach is different, and the timing is quite specific, isn't it?
Yes. For exposure in a non-immune woman at 20 weeks gestation, the notes advise giving either VZIG or antiviral medications, like azaclovir or valacyclovir. That's the first difference. You have a choice of VZIG or antivirals.
Okay, a choice there. But the timing...
But the crucial, slightly counterintuitive timing here is that you give these interventions between day 7 and day 14 after the exposure.
Wait, day 7 to day 14 after the exposure, not immediately. That feels delayed.
It does seem delayed compared to many post-exposure prophylaxis scenarios. It's a really specific window mentioned in these notes.
Do the notes give a reason for that delay? Something about effectiveness or...
They briefly mention things like effectiveness studies potentially supporting that window, or maybe even supply issues historically influencing guidelines, but they don't dwell on it. For revision, the absolute high-yield fact is just knowing that specific 7-14-day window for intervention if the non-immune woman is 20 weeks post-exposure.
Okay, that timing split based on 20 weeks gestation is absolutely vital for post-exposure prophylaxis in non-immune women. VZIG promptly if 20 weeks, but VZIG or antivirals given specifically between day 7 and day 14 if 20 weeks.
That distinction is a memory tip in itself, really. Remember, the 20-week cutoff changes the timing and the drug options for prophylaxis.
Definitely one to highlight. Now, what if, despite everything, the pregnant woman actually develops chickenpox? She gets the rash. What's the management then?
First step mentioned in the notes. Seek specialist advice immediately. This isn't something to manage routinely in primary care. You need infectious diseases or obstetric specialists involved.
Yeah, specialist input is key. And then treatment for the active infection itself.
If she develops the rash and is at 20 weeks gestation, oral azaclovir is recommended.
Recommended.
And it should be started within 24 hours of the rash appearing. That within 24 hours window is crucial for effectiveness to try and reduce severity and complications.
Another critical timing. Start azaclovir quickly, within a day of the rash onset, if she's 20 weeks or more. What if she gets the rash but is less than 20 weeks gestation?
The notes are a bit more cautious here. They state that azaclovir is considered with caution if she is 20 weeks. The recommendation is less definitive than for later pregnancy. There are theoretical concerns about drug safety earlier on, though evidence is debated.
So, again, that 20-week cutoff matters for treatment decisions, too.
Absolutely.
The notes also mention considering antiviral medications like acyclovir for severe cases in general, which makes sense, right? Linking back to that maternal pneumonitis risk we mentioned way back at the start. If the infection is severe, antivirals are definitely part of the picture.
Right. Antivirals have a role both for prophylaxis in that specific 20-week day 7-14 window and for treating active infection, particularly if it happens later in pregnancy or if the mother becomes significantly unwell.
Yeah, this management section is packed. The timings, the gestational age cutoffs, that's definitely where the focus needs to be for revision.
It really is. That's where the points are in exams and where the critical clinical decisions lie.
Absolutely. That's the core clinical application. So, After navigating potential exposure or infection and its management, what's the general outlook? Let's talk prognosis.
Well, the notes make it clear the prognosis depends heavily on those two key factors we keep coming back to: the gestational age at which the exposure and potential infection occur, and crucially, the mother's immune status.
Right, those dictate both risk and management, so they dictate outcome too. And generally, what's the outcome for most cases?
Most exposed women, especially if they are immune or if they receive timely prophylaxis when needed, and most infected women who don't develop severe complications. They recover well, according to the notes. The
Oh,
baby is often unaffected too.
that's reassuring. But the notes do reiterate that high-risk period again in the prognosis section, don't they?
Yes, reinforcing that there's a higher risk of fetal complications, especially in the first trimester, tying back once more to that FVS risk window before 20 weeks, circling back to that early risk.
Okay. Finally, let's explicitly list the complications mentioned. We've touched on these throughout, but it's good to just consolidate them.
Okay, the primary fetal complications listed are congenital varicella syndrome, CVS, and general fetal abnormalities.
And linking back to our earlier discussion, the notes describe the outcomes of CVS as including those skin, limb, neurological, and eye abnormalities we talked about with FVS. It seems the notes use CVS and FVS somewhat interchangeably here.
Yeah, or perhaps FES is considered the specific pattern of abnormalities seen within the broader category of CVS due to early infection. Essentially, they're describing the consequences for the baby when the virus is transmitted across the placenta early on.
Got it. And for maternal complications.
The main one the notes specifically list is pneumonia. They note it's less common than the fetal issues, but, as we said, a significant risk if it occurs, potentially life-threatening for the mother.
And is there a positive note on complications?
Yes, the notes do emphasize at the end of the complications section that early diagnosis and appropriate management do make a difference. Intervention works. It reduces the risk of these serious complications for both mother and baby.
Phew. Okay. We've really taken those notes and tried to pull out the essential threads on chickenpox exposure and pregnancy.
Yeah, and if we were to distill the absolute core message from this whole deep dive, it really has to be that understanding the timing of exposure relative to gestation is the fundamental driver here.
It really is.
It determines the specific risks you're most worried about for the baby, that early FES risk versus the perinatal severe neonatal risk.
Yeah.
And it dictates those crucial management decisions. When and how you give VZIG or antivirals. It all hinges on timing and immunity.
Absolutely. And if you're targeting these notes for revision, maybe for the MSRA, make sure you've really locked in those key numbers and timings we pulled out. That approximate 1% FES risk before 20 weeks. That alarming 20% neonatal fatality risk if the mother's rash is right around delivery.
Yeah, that 5 days before to 2 days after a window.
And the specific rules for VZIG and aciclovir based on gestational age, that 20-week cutoff, and whether you're preventing infection post-exposure versus treating active disease, those are absolute gold dust for recall.
Those distinctions are definitely high-yield points that frequently appear in clinical scenarios and exam questions.
So to leave you with a final thought, something to mull over based on everything we've covered.
Yeah.
Given just how profoundly the timing of exposure impacts both the specific risks to the baby and the required management steps, what does all of this information underscore about the absolute importance of knowing a pregnant woman's varicella immunity status as early as possible in her pregnancy?
That's a great point. It really elevates that simple immunity blood test, doesn't it? From just being a routine check to being a foundational piece of information. Information that informs critical, time-sensitive interventions down the line if exposure happens.
Yeah.
It's not just data. It's really key to a whole potential management pathway. Knowing it early gives you a huge head start.
A perfect point to end on. Thank you for sharing this incredibly important source material with us and joining for this focused deep dive.
It's definitely a complex topic, but hopefully with clear, high-stakes points. We hope this breakdown makes it significantly clearer and helps solidify the facts for you.
And if you are deep in the revision trenches, especially getting ready for something like the MSRA, remember to explore pastthemsra.com for support and resources.
Absolutely. And for completely free revision resources to get you started, you can also head over to freemsary.com.
Keep learning, keep asking questions, and we'll catch you on the next deep dive.